and the organizing committee for inviting me today in this prestigious meeting. We've been always working together, in the Ophthalmology department and the Neurology department, and that's why I called my presentation Pediatric Optic Neuritis and Crossing Bridges. Why am I here? There's always a continuous fruitful collaboration with the Pediatric Neurology department. They're always in association with us, and they send us referral notes for fundus examination or examination of their children. And this time, things are very different. It has been different since mid of December 2024. We've got series of children, mostly less than 10 years, up to 12 years of age. Their only presentation to the casualty department at Abu Rish Hospital was sudden drop or acute painless loss of vision. They had no history of any association or any systemic disease, no recent vaccination, no viral infection. And the only positive sign that they used to mention that they used to have common cold 2 or 3 weeks prior to their first presentation. We had 7 cases, but I'm going to display just 4 with 4 different presentations, and we're going to discuss these together. We have case number 1. He was a male patient, 4 years old. He had sudden onset of acute painless loss of vision. He was preceded by common cold 2 weeks earlier. His ophthalmic examination revealed visual acuity of hand motion in the right eye and just 160 in the left eye. He had unsustained pupillary reactions, and his fundus showed bilateral mild edema of both optic discs. That's the picture of his fundus. But it was a bit different because he had bilateral nasal optic disc edema, and he had attenuated retinal vessels, which means for us that it's a hypoxic event or a hypoxic insult. And that's why we put that into consideration. He had retinal mottling, and he had by fluorescein angiography, which is an investigation that we did him. He had hypoperfusion of the optic disc, hypoperfusion of the choroid, and hypoperfusion of the retina. He underwent all his labs, and they were all normal, except that the CRP was a bit high. His imaging, MRI brain and MRI whole spine, were completely normal. He did CT chest as well, and it was completely normal. And we performed for him the flash visual evoked potential, which showed that he had marked delay in his conduction to the brain. He received his treatment, which was in the form of pulse steroids for 3 days, and then Plex for 2 sessions. And then he received successively 2 endoxan doses of 500 milligrams per meter squared. He maintained his treatment by oral steroids, which was pretzel syrup, twice daily for 6 weeks. Sorry? Plasmapheresis? ده هم اللي بيكتبوها كده. Plasmapheresis. Okay. هم على فكرة اللي بيكتبوها يا دكتور مرتضى مش أنا. أنا قصدي يعني الكلام ده أنا واخداه من عنده. Throughout their treatment, and I just want you to know that I'm just an ophthalmologist who's interested in pediatric neuro-ophthalmology. Throughout their treatment, the visual acuity improved from hand motion in the right eye and 160 in the left eye to 360 in both eyes, and then 618 in both eyes. 618, that it means that he can count lines on the chart projected to him. He still had unsustained pupillary reactions and defective color vision. From this picture, again, showed vascular insufficiency by the end of actually one month and 1 week. Vascular insufficiency, bilateral pallor of both optic discs, attenuation of the retinal vessels, hyperperfusion again of the optic disc and of the retina and of the choroid. Because we were suspecting that he might have a vascular insult and he might be having anterior ischemic optical neuropathy, I just wanted to check that he had a proper fluorescein OCT angiography. What is OCT angiography? It's a certain investigation that we do not use a dye, we do not use fluorescein, but it measures the capillary plexus density, which supplies the optic nerve head and which supplies the retina. And they were perfect. There was nothing. There was no hypoperfusion, evident by OCT angiography. and his retinal nerve fiber layer and the ganglion cell layer, which are retinal layers, were consistent with his age group. By the end of March, he showed marked improvement on therapy. His visual acuity turned to 6.6. He had unsustained pupillary reactions. His color vision improved so much. His fundus showed bilateral pale optic discs, attenuated vessels, but he had vision. He regained his vision totally. He became 6.6 vision. Unfortunately, I did not photograph him prior to his treatment because actually it was so dramatic that the parents were coming carrying a child who's blind and me photographing him. So I didn't do that prior to his treatment. Case number 2, male patient, 5 years old. He came complaining of acute painless loss of vision, preceded by common cold 2 weeks prior to his first presentation. But he actually presented a bit late. He presented 25 days after the onset of his visual loss. He had no history of any systemic problem or trauma or fever. On ophthalmic examination, he showed vision, which was hand motion bilaterally, unsustained pupillary reaction. His fundus showed pale optic discs bilaterally and marked attenuation of the retinal blood vessels, which is again consistent with a vascular insult or maybe hypoxia. And this is the fundus picture of the patient. He has bilateral pale optic discs. The retinal vessels look like threads. They are not the normal caliber of the retinal blood vessels. His labs were normal except for the P-ANCA, which was a bit high, and we thought of that he might be having microangiopathy or vasculitis. His ERG and VEP showed that he had marked the conduction deficit in both tests, which means that the optic nerve is affected. He is having optic neuropathy. His MRI, brain, and orbit were completely normal. There was nothing mentioned in them. His treatment was in the pattern of the Jan, when he first presented. He received his pulse steroids, plasmapheresis, and then in Feb, he received rituximab, and in March, he tapered his steroids to the oral form, which is Pretsol syrup twice daily. And the outcome was, after 1.5 months of treatment, that the patient regained his vision, one more time, from hand motion bilaterally to 6.24 by mid of March. Couldn't do his color vision because he was a bit young and he did not understand the colors. He still maintained his sluggish pupillary reaction, and the fundus remained having the same picture. The third case was a 12 years old female patient who presented with bilateral asymmetrical marked diminution of vision. She had history of fever, which is 39.5 degrees centigrade, resistant to treatment, no cough, no flu, and no joint pains. Her father was a pediatrician. That's why he did her a lot of tests and a lot of labs and a lot of imaging. She had leg edema, mild ascites, and pleural effusion associated with her fever, where she was admitted to an ICU in our hospital, Abu Rish, when she was referred to us for her ophthalmic examination after that. Her ophthalmic examination revealed that she had counting fingers 30 centimeters vision in her right eye, 360 counting fingers in her left eye. She had relative afferent pupillary defect in her right eye. The color vision was markedly affected in her right eye and preserved in her left. Her fundus picture showed bilateral optic disc edema. This was a significant optic disc edema. In the right eye, it was associated with peripapillary hemorrhages as well. The retinal vessels were tortuous and the retina was a bit elevated. She underwent a lot of labs. She had a lot of laboratory workup actually because, as I said, her father was a pediatrician and he did her everything. Everything regarding the vasculitis profile, regarding infectious causes, regarding viral causes. He did her so many labs actually. Radiological workup, she did MRI brain and MRA and MRV. She underwent echocardiography and chest x-ray. When she did all of that, she started in our neurology department her systemic treatment in the form of antibiotics and aspirin and other things. I think they just wanted to cover if she has any infectious cause till the labs came out. Her imaging was normal. She had mild pleural effusion, increased basal and pericardial bronchovascular markings in her chest x-ray. And then she started, when we diagnosed her as papillitis or optic neuritis, she received an immediate treatment of pulse steroids of 20 milligram per kg per day for 3 days, followed by maintenance steroid dose of 2 milligrams per kg afterwards. She underwent plasmapheresis 4 sessions every other day, and then she took intravenous immunoglobulins for 2 days. What about her vision? Her vision improved to 360 in her right eye and then 6.6 in her left eye. She still maintained her relative afferent pupillary defect in the right eye, and she maintained brisk pupillary reaction in her left eye. She had poor color vision in her right eye, and she got it intact in her left eye, and there was a resolution of the optic disc and the hemorrhages completely. A month later, her vision improved in her right eye to 636 and her left eye to 6.6. She still had pale optic discs, which is the healing process of the neuritis. She had post-papillitic gliosis, peripapillary gliosis, and we wanted to perform it because she was very smart and she was 12 years old. So why not to perform her automated perimetry, which is the measurement of field of vision, so that we can routinely assess if there is any improvement or there is any defect. And actually, we started that in March, where we did her field of vision, and she showed marked reduction in the retinal sensitivity in both eyes, more pronounced in her right eye than her left eye. And when we repeated that by the mid of May, we found that it improved actually in the right eye and in the left eye when compared to the first field of vision. This is the last case, case 4. He was a 9-year-old male patient, presented first week of April with marked diminution of vision bilaterally. He had no history of fever, vaccination, or any systemic association. The ophthalmic examination showed visual acuity of hand motion in both eyes, sluggish pupillary reactions bilaterally, and the fundus picture of his right eye showed disc edema, while the left eye showed central retinal vein occlusion, which is an occlusive disease. And on looking to his fundus picture, we can see the hemorrhages, optic disc edema, and tortuous veins, retinal veins, with a periphlebitis and scattered retinal hemorrhages. Fundus fluorescein angiography was performed, and visual evoked potential was performed as well, which was conclusive that he had a pre-chiasmatic primarily demyelinating lesion, and they just diagnosed him as he might be having a demyelinating disease through the E.U.P. Imaging, the imaging was completely normal. He had nothing in his imaging brain MRI. And the body fluids, he had an elevated LDH and elevated serum and CSF bands. But he had no oligoclonal bands. I think bands refer to oligoclonal bands as well, right? But actually this was inconclusive as well, because it represents an inflammatory condition but not a demyelination necessarily. Within a month, the patient was diagnosed as primarily inflammatory optic neuritis. He received intravenous pulse steroids for 5 days. Visual acuity improved to 360 in his right eye and counting fingers in his 50 centimeters in his left eye. Then he underwent 5 sessions of plasmapheresis, where the visual acuity improved to 618 in his right eye, 360 in his left eye, and he still had sluggish pupillary reaction. Okay. What was in common between these 4 patients? That they all had positive COVID. Okay, they had positive interleukin-6, it was very high. COVID-19 anti-spike, it was very high in the 4 of them. And this is one of the very few reports of optic neuritis, pediatric optic neuritis post-COVID, because they had no other manifestations of COVID except their labs. And their labs was done. Actually, the first one was done by mere chance when we asked what can be wrong with this child, and we asked for a COVID panel. And when we got it positive, we started that as a routine in the rest of the children, and we got 4 out of the 7 with post-COVID optic neuritis. COVID-19 and primary optic neuritis, how does it actually yield optic neuritis? Through autoimmune mimicry, neurotoxic effect of the virus, hyperviscosity and hypercoagulability, and hypoxia. Pediatric optic neuritis is very rare if compared to adults. It's characterized by being bilateral in cases less than 10 years of age and unilateral more than 10 years of age. Prepubertal age, the males and females are the same. Postpubertal females exceed males in the predilection of optic neuritis. They always manifest with profound loss of vision, which is less than in adults. 85 to 90% of visual recovery takes place in children, which is on the contrary in adults, only 50% recover their visual acuity. They do not present with retrobulbar neuritis or pain during eye movements as in adults. They just simply manifest with the drop of vision. Defective color vision, decreased contrast sensitivity are the hallmark of pediatric optic neuritis. The field of vision is usually affected whether central or centrocecal scotometer may be present. The visual evoked potential is very useful, especially in pre-verbal children with pediatric optic neuritis. It can be idiopathic, post-viral, post-vaccination, and can be the first manifestation in demyelinating diseases in children exceeding 10 years of age, can be part of ADAM in children less than 10 years of age. There's a study, prospective, this is the only prospective study of pediatric optic neuritis, which was testing the outcome and the high contrast monocular visual acuity and the contrast sensitivity in those patients when followed up for 6 months and then 2 years. So the diagnostic workup was, first of all, we have to differentiate between the papillitis or optic neuritis from papilledema. So any cause of disc swelling, we have to rule out infectious and neoplastic causes, MRI brain and spinal cord, lumbar puncture to test for the opening pressure, and CSF analysis for protein, glucose, cells, oligoclonal bands, PCR for viral infections. We have to test for the anti-aquapurin for anti-MOG antibodies if neuromyelitis optica is suspected. We have to perform serology for autoimmune diseases if suspected, labs for TB and sarcoidosis as well. So to wrap up, collaboration is so much needed between the neurology and ophthalmology departments to offer better service for our patients. Early diagnosis, prompt intervention in these children saved their vision, which is for us their life. We had one same complaint, which is marked diminution of vision, one same diagnosis, which is optic neuritis, different ophthalmic clinical presentations, but one thing to be incriminated, which was COVID-19 virus. To wrap up, I think we made a lot of effort. We spent a lot of time, but actually the result is very, it's great to see children who were not moving at all, who were rendered blind, and we were carried because they did not have any vision, and then they keep moving and running and coming and going. This is great. By the end of my talk, I would like to acknowledge my team, which is Ibrahim Maqbool, Mustafa Wagih, Islam Mitwali, Shireen Muhammad, for following up these patients and for getting me all the data in details. Thank you so much.
Thank you very much, my dear colleague, Professor Dr. Ghada, for this interesting talk. We all know that viral optic neuritis is one of the most common causes of pediatric optic neuritis. There is a recent trend in incriminating COVID vaccination in any inflammation or any unexplained occurrence of disease, but nice in this case that you were able to prove it, because not always we had a proof or any laboratory investigations. Also, I tend to believe that common things are common, so we should also think of something like Epstein-Barr virus, like more common viruses that may also be the cause for such cases. Thank you very much once again.
Thank you.
And now let me introduce my dear colleague, Professor Dr. Hafiz Bazara. Sorry.
خاص for your dedication. حضرتك دايما معانا الحقيقة يعني، ودايما أكلمها ألاقيه على طول استجابة سريعة. بعتيه العين الساعة 8 الصبح، الساعة 9 همشي. فيعني هي يعني حد فعلا very very dedicated. Thank you very much وميرسي جدا على الحالات. الحقيقة I'm feeling proud to work with you, with the ophthalmology unit. To save the vision of those kids is really amazing, and actually turning off their whole lives because their vision is restored. Thank you very much, Dr.
Thank
Ghada
you
and
so
the
much. Thank
ophthalmology
you so
team.
much for your kind invitation. Thank you.
guidelines في الأوبتيك نيورايتس عشان دكتور حافظ موجود معانا. احنا بنبدأ ب methylprednisolone IV. If there is no good response, which is usually there, we go immediately for plasma exchange because this saves the vision. And I'm saying this because Dr. Hafiz معانا النهارده وهو يعني head of the pediatric ICU, because this is the guidelines actually everywhere. Thank you.
Thank you so much. Thank you. Merci.
Thank you again. And now let's hear our dear colleague, Professor Dr. Hafiz Bazara, who is going to talk about immunomodulatory therapy in critical care neurology.